Welcome back to Rounds, Episode 3. Today we step beyond the common and head into the subtle. Hormones, bone marrow, nerves, and joints. We have 5 patients, 5 mysteries, and a rule that never changes. The pattern is the diagnosis. I'm here to provide the clues, and you're here to commit to the answer. Let's begin. Here is how each case unfolds. We start with the history, where the answers are often hiding in plain sight. Then the examination, followed by the investigations. Then the beat that really matters. You decide. Pause the video, commit to a diagnosis, and then we move to the reveal and the clinical pearls you'll carry with you. An honest guess beats a silent shrug every time. Today's board. Case 1. A man gaining weight with unexpected weakness. Case 2. A woman with a changing personality and persistent back pain. Case 3. A man with a weakening, twitching hand. Case 4. A woman with double vision that worsens throughout the day. In Case 5, a man with a hot, swollen knee and fever. 5 patterns to learn. Case 1. A 64-year-old retired miner. In 6 months, he's gained 8 kilograms and is constantly hungry. But he's also struggling to stand and climb stairs. Gaining weight while losing strength is a contradiction. Fat doesn't make muscles weak, but one hormone in excess can do both. Keep that in mind. Look at the history. He has weight gain and constant hunger, proximal muscle weakness, skin so thin it bruises easily, and depression without any psychiatric background. And don't forget he smokes 30 cigarettes a day. All these symptoms are threads in a single tapestry. Let's see how the exam ties them together. The examination reveals the distribution: central fat, but spared limbs. Blood pressure is significantly elevated. Power testing confirms weakness specifically in the proximal muscles. The skin is paper thin, with purple striae and spontaneous bruising. These aren't 5 separate problems. They are one distinct clinical pattern. The labs provide the final clues. He has new onset hyperglycemia, hypokalemia, and high blood pressure. His liver enzymes are normal, which is a vital detail, and his chest X-ray is clean. We have a cluster of metabolic and physical findings, all pointing toward one hormone in excess. Can you name it? Pause the video and take a moment. First, what is the diagnosis and the responsible hormone? Second, how do you prove the excess and localize the source? You have the clues: central fat, proximal weakness, skin changes, diabetes, low potassium, and hypertension. Commit to your answers before we reveal the truth. The diagnosis is Cushing's syndrome, caused by cortisol excess. Cortisol acts by breaking down structural proteins, leading to muscle weakness and skin fragility, and it promotes central fat distribution. It also disrupts metabolic balance, pushing up blood sugar and pressure while lowering potassium. Remember, Cushing's syndrome is the condition. Cushing's disease is the specific pituitary cause. The workup follows a 2-step process. First, confirm cortisol excess with a midnight cortisol test or dexamethasone suppression. Second, measure ACTH to localize the source. In our patient, high ACTH and a pituitary MRI showing a microadenoma confirmed the diagnosis. We ruled out ectopic causes because his chest X-ray was normal. The treatment of choice is transsphenoidal surgery. Successfully removing the microadenoma cures the condition and restores health. For your clinical pearls, always look for Cushing's when you see rapid onset obesity, and never forget to check the medication list for steroids first. In a smoker with severe symptoms, always consider an ectopic source. Case 2. A 62-year-old woman is here because of a personality change. Her husband reports irritability and confusion. She also mentions a worsening ache in her back and abdominal discomfort. These symptoms seem unrelated, but our goal is to find the common thread that connects her mind, her back, and her gut. Reviewing her history, we see irritability and confusion, 2 months of progressive back pain, and constipation. She attributes the constipation to her painkillers, but that doesn't fit, since she is only taking acetaminophen and ibuprofen. This inconsistency is a major clue. When a patient's explanation doesn't make sense, the symptom becomes a central puzzle piece. The physical exam shows pallor and tenderness over the lower thoracic spine. Her labs confirm pancytopenia, a reduction in red cells, white cells, and platelets. Since all 3 lines are manufactured in the bone marrow, this points to something crowding the factory. We also see an elevated ESR and mild creatinine increase. Something is affecting her bone marrow. The clinician's strategy here is to look for one number that ties it all together. We have confusion, constipation, bone pain, and fatigue. These point directly to hypercalcemia. Recall the classic mnemonic: stones, bones, abdominal groans, and psychic moans. This covers almost everything she is feeling. Now we have to identify why her calcium is high. Pause the video. Question 1. What underlying diagnosis best ties together a high calcium, a pancytopenia, focal spine pain, and an ESR of 96? Question 2. Name the 3 investigations that would confirm your answer. Think blood, pictures, and tissue. She is 62, with a tender spine and 3 failing cell lines. Commit to the diagnosis and the proof. Reveals next. The diagnosis is multiple myeloma, a cancer of plasma cells multiplying inside the bone marrow. It explains everything. The crowded marrow causes pancytopenia, bone erosion causes pain and hypercalcemia, and the abnormal antibody protein drives the ESR up and clogs the kidneys, elevating her creatinine. Remember to always correct calcium levels and check phosphate to differentiate causes. Confirmation comes in 3 moves: blood, pictures, and tissue. Protein electrophoresis identifies the monoclonal band in the blood. Skeletal X-rays show the characteristic punched-out lytic lesions. Finally, a bone marrow biopsy provides the definitive proof. Parathyroid hormone should be suppressed in cases of malignancy-associated hypercalcemia. Its status helps finalize the diagnosis. Management starts with urgent rehydration to manage the hypercalcemia. Subsequent treatment involves steroids and chemotherapy, with stem cell transplantation for eligible patients. Honest communication is vital. This condition is treatable, often leading to long remissions, but usually not curable. Always investigate red flags like weight loss or marrow failure in patients with unexplained back pain. Case 3. A 67-year-old retired lecturer presents with a weakening left hand, muscle wasting, and cramps. Critically, he mentions choking on drinks. In neurology, the history and examination are the definitive diagnostic tools. We must now look beyond one limb to understand what is failing in this patient. His history is telling. We see progressive wasting in the left hand, exacerbated by use. Painful forearm cramps are an early clue. The choking episodes indicate bulbar involvement, suggesting the problem has spread to the brainstem. These symptoms, occurring in a patient with a history of hypertension, require a careful, structured neurological examination to interpret correctly. The exam reveals a paradox. Lower motor neuron signs like muscle wasting and fasciculations are present alongside upper motor neuron findings, specifically brisk reflexes. Notably, his sensation is entirely normal. This combination of motor deficits without sensory loss is the hallmark of a specific, serious neurological diagnosis that we must carefully evaluate. Pause the video and consider the paradox. What diagnosis explains the simultaneous presence of lower and upper motor neuron signs while leaving sensation untouched? Furthermore, what does the speech and swallowing impairment reveal about the extent of the disease? Reflect on these findings, as they are crucial for narrowing down the diagnosis. The diagnosis is motor neuron disease, most commonly amyotrophic lateral sclerosis, or ALS. It involves the progressive destruction of motor neurons in the spinal cord, brainstem, and cortex. The sensory system is spared, which is why sensation remains intact. The combination of wasting, fasciculations, and brisk reflexes is the classic presentation of this condition. Before finalizing such a diagnosis, we must exclude lookalikes. Cervical myelopathy can mimic these symptoms, but imaging rules it out. Myasthenia gravis also presents with weakness, but without wasting or fasciculations. Stroke, brachial plexus lesions, and motor neuropathies must also be considered. A thorough workup is mandatory to ensure an accurate diagnosis. Communicating this diagnosis requires honesty and compassion. We focus on a multidisciplinary approach, utilizing therapy, nutrition, and communication devices as the disease progresses. While incurable, we can support quality of life with interventions like gastrostomy for nutrition and non-invasive ventilation for breathing support. The team's support is essential for both the patient and his family. Key takeaways. Motor neuron disease often begins with localized hand weakness. Fasciculations are a classic sign, and the coexistence of wasting and brisk reflexes creates a diagnostic paradox. Most importantly, normal sensation is the key differentiator from other conditions. Let's move to our next case, where weakness worsens with use, but in a very different way. Case 4. A 43-year-old woman describes a unique pattern. She is nearly normal in the morning, but by evening, she experiences double vision, drooping eyelids, and a fading voice. Chewing dinner is a struggle. Her weakness follows a daily clock, consistently worsening by the end of the day. This timing is the most significant clue. Her history shows 3 months of symptoms that affect specific muscles. Vision, swallowing, and speaking all degrade as her day progresses. This fatigue isn't just about general tiredness, it's specific muscle exhaustion. She is otherwise healthy, making this presentation even more distinct. Now, we examine her to confirm the pattern of her weakness. The examination confirms our suspicion. Power is normal at rest, but repeated testing reveals a rapid fade. Sustained upward gaze causes visible ptosis. Crucially, reflexes and sensation are normal, and there is no muscle wasting or fasciculations. The muscle itself is healthy. It's the signaling pathway that is fatiguing. This is a classic presentation of a neuromuscular junction disorder. Pause the video. Question 1. What is the diagnosis? And be anatomically precise. Where in the pathway from brain to muscle does it strike? Question 2. Name the tests that confirm it. Electrical, chemical, and antibody, and the one scan this diagnosis always demands. Your clues: fatigable weakness, worse by evening, ptosis on sustained upgaze, and healthy-looking muscle. The diagnosis is myasthenia gravis, an autoimmune attack on the neuromuscular junction. Antibodies block acetylcholine receptors, causing power to fade with repeated use. Unlike motor neuron disease, the neuron is fine. The signal simply fails. It favors eyes, lids, bulbar muscles, and neck. Remember, mornings are good, evenings are bad, and respiratory failure is the ultimate danger. Confirmation requires an electrical, chemical, and antibody approach. EMG shows a decremental response, a signal fading with repetition. The edrophonium test uses an anticholinesterase to flood the junction and briefly restore power. Antibodies against acetylcholine receptors are found in 90% of cases. Always order a chest CT because the thymus gland is often an accomplice with a thymoma. Treatment balances calming the immune system with boosting the signal. Corticosteroids suppress the autoimmune attack. Anticholinesterase drugs enhance neurotransmission, though they have side effects. Thymectomy is often effective, especially early on. Always watch respiratory function closely. Lookalikes include myotonic dystrophy, polymyositis, and endocrine myopathies, which you must distinguish from myasthenia. Remember these 3 pearls. Fatigability is the diagnostic hallmark. Learn the specific muscles myasthenia targets first, and never skip the chest CT, as the thymus may be involved. One case remains, and it arrives in the emergency department with one very angry knee. Our final case: a 35-year-old businessman reports a swollen, hot right knee that appeared over 36 hours. No trauma, but he feels feverish and notes his eyes are sore. He returned from a business trip to Thailand 3 weeks ago. A single hot joint is a medical emergency until proven otherwise. The threads: a fast-onset painful knee, systemic fever, sore eyes, and recent travel. None of these are minor, especially in combination. This is a multi-system puzzle hidden within a local joint complaint. We need to look closely at every clue: the knee, the fever, the eyes, and that history of foreign travel. Examination confirms our suspicion: fever, red eyes suggesting conjunctivitis, and a distinct macular rash on his palms and soles. The knee is a classic monoarthritis. Labs show elevated inflammation. Crucially, a hot, swollen, feverish joint is septic arthritis until the aspirate proves otherwise. Perform the aspiration before labeling the disease. Pause the video. Question 1. What is the diagnosis? And what specific question must you ask this patient? Question 2. Name the 2 procedures required to rule out dangerous mimics. One involves a needle, one a swab. We have conjunctivitis, a palm and sole rash, and a history of foreign travel. Everything is connected. How do you confirm it? The diagnosis is reactive arthritis. It is an immune reaction occurring weeks after a genital or gut infection. We asked about a urethral discharge, which he confirmed. This confirms the trigger, likely chlamydia. The classic triad includes arthritis, conjunctivitis, and urethritis. The rash, keratoderma blennorrhagitsa, is a recognized and diagnostic companion. Always keep a broad differential for a hot joint. Septic arthritis is the top emergency, requiring urgent assessment. Gonococcal arthritis, crystal-induced gout or pseudogout, and other seronegative arthritides must be considered. Lyme disease and viral causes are also on the list. A joint aspirate, gram stain, and polarized microscopy is the single most important diagnostic step. Management involves 4 steps: aspirate the knee, swab for infections, treat inflammation, and screen partners. Aspirate to exclude sepsis and crystals. Swab to identify the trigger and treat with antibiotics. Use NSAIDs or steroids to settle the joint. Finally, treat both the patient and his partner for potential co-infections, ensuring you screen for HIV, syphilis, and hepatitis. Remember, always aspirate a hot joint before labeling it. Reactive arthritis often presents with the classic triad of arthritis, conjunctivitis, and urethritis, though you may need to ask directly to uncover the urethral component. Finally, take a whole-person approach. Treat the infection, screen the partner, and consider other sexually transmitted infections that often travel together. Recapping our 5 cases, Cushing's is an endocrine question, not a lifestyle one. When symptoms scatter, hunt for the single common denominator. Always map weakness to the nervous system wiring. Ask when for weakness, as fatigability is a diagnosis itself. And finally, a hot joint is septic until proven otherwise. History, exam, targeted testing, and verification. Your roadmap. Rounds are complete. We've covered Cushing's, multiple myeloma, motor neuron disease, myasthenia gravis, and reactive arthritis. You are now familiar with 5 distinct patterns. If this episode helped refine your clinical eye, please share it and subscribe. New patients will arrive in the next episode, so keep practicing. See you then.